Yes, and we're live. Hi, everyone. Welcome to Talking Live with Macy. Once again, we're waiting for 15 people to join us on the stream. So if you're tuning in right now, you know what to do. Share this with your friends, with your family, get them to join in, to tune in to understand more about psoriasis and to understand treatment options, to management, and anything you would like to ask about psoriasis. We're trying to get more people to join us on the stream so that they can ask questions and we can be educated about psoriasis. This is something very important to all of us. And I feel that it should be public knowledge, not just for psoriasis patients or survivors, or rather psoriasis patients in general, or their relatives. So I know many of you have questions. How do you join this stream? If you're on the stream right now, just click the share button on Facebook and you can share it on WhatsApp, Facebook, Instagram, any of the social media platforms because it shares the link directly, or you can copy and paste it in the URL and you can send it to your friends and family. That's how you join the stream because this is a live stream. There is no premiere to this stream. So we're waiting for two more people to join us before we officially begin because we have a jam-packed session today. We have two amazing guests joining for Talking Live with Macy. So please stay tuned, join in, share this with your friends, with your family. It looks like there are 15 people already officially on the stream. So it's time for me to begin. Welcome to Talking Life with Macy. For those of you who are first timers, this is a bi-weekly talk show every Sunday at 3:30 p.m. where we talk about disease awareness, we talk about cancer, we talk about health in general, and very important topics, I believe. But this is the first part of a three-part series on psoriasis and a public education program. And this is something that we want to share with people because World Psoriasis Day actually just passed on 29th of October. I know we are just 1 month late, but at least we're doing it. That's how I see it. So right now, if you're tuning in, you have friends and family wanting to know more about psoriasis, or you are wondering what is it, do share this with them because this is something important for them to know. So World Psoriasis Day is commemorated every 29th of October each year. And there is a special theme. This year's theme is Time to be United. To continue to raise awareness and to educate the greater community about psoriasis, we are united this afternoon at 3:30 p.m. to kickstart a three-part series on psoriasis. We are honored to have both the Dermatological Society Malaysia and Psoriasis Association Malaysia to support this three-series educational program. This disease awareness program is organized and supported by AbbVie. Now, I'm going to do a disclaimer, so bear with me. This session today is for the purpose of disease awareness. It's not meant to be promotional in nature, nor is it an avenue to promote any particular product. For any medical treatment or health related inquiries, we would like to ask you to consult your medical doctor for advice and reserve the right to filter, remove, or respond to any posted questions or comments accordingly. So, if you're from any of the societies or you're a psoriasis patient, welcome to the show. I'm glad to see you and have you on. This, like I said, this is the first episode. We have three episodes. Today's format is, if you're a regular, today's format is going to be slightly different because we're going to have the same format where today's the introduction, then we have our special expert on the show where we're going to ask, I'm going to ask him questions. We're going to have a discussion, followed by questions for the audience. We're also going to have a myth debunking with our special guest. After that, we're going to end the show with a 10-minute special breathing technique program by Jojo Struys. So do stay on with us till the end because the breathing technique is meant to help us alleviate stress and reduce anxiety. And that's perfect for psoriasis patients. So let me introduce our special guest for today. He is a consultant dermatologist and internal medicine specialist. He actively immerses himself in research work and publication. He is also a reviewer for journals and he's a regular speaker in both local and international conferences. He was the former head of dermatology of the state of Pahang and the Hospital of Sungai Buloh. He was also previously a honorary lecturer for a few universities. He's currently the chairperson of the Cosmetic Dermatology and Laser Medicine Board of Malaysia, member of the main credentialing and privileging committee of Aesthetic Medical Practice, EXCO member of Malaysia Dermatology Association, and member of the Cochrane Skin Group. He is currently a consultant dermatologist at Gleneagles, KL, and Desa Park City in KL. So I'm so glad to have our special expert on. We have Dr. Peter Ching.
Hi, hi. Thanks, Maisie. Hi, everyone. Good
Hi, Dr.
afternoon,
Peter.
everyone. Hi.
I
Glad to be
believe
here.
today you'll be sharing. Yeah, I'm so glad to have you. You're going to share with
Thank
us
you.
your expert opinions to educate us further about psoriasis and to understand the journey of psoriasis patients, to share with us what's new in management of psoriasis, and to help patients improve their quality of life. So
Yeah,
today's focus is psoriasis as clear as you can get.
yeah.
So,
So
Dr. Peter, I'm just going
bring
to
on all
jump.
the
Yeah, I'm
questions.
going to
Yeah,
bring on all the questions for you. I have 7 questions of my own, and then we'll open it to the public.
sure.
So, the first question is, what is psoriasis, and is it a lifelong condition?
So psoriasis, what you will see in patients with psoriasis is you will see rash, but this rash is very peculiar to psoriasis. That means when we see the rash, it is most of the time pinkish in color. Only in darker skin type, for example, Indian patients, we see a bit more purplish color. But generally, it's this what we call salmon pink color, and the scales is silvery scales, and it's larger as compared to your dandruff. And these lesions can
Okay.
happen on the scalp. It can happen commonly on the extensors, that means your elbows, your knees. It can affect your nails. It can affect your joints. And nowadays, we know it's not just a skin problem. It also affects what we call a metabolic syndrome. That means patients with psoriasis, they are at increased risk of getting hypertension,
Mm,
hypercholesterol, obesity, diabetes, and eventually heart disease. Mm,
I
Yeah.
see. So, you would say that it's a lifelong condition as well?
Yes, yes, it is what I call chronic disease, you know. So when patients come to
Yes.
me, when we
Okay.
discuss about treatment, I always emphasize that, we can control your disease really well as if you don't have a skin disease. But it is
Wow.
not to cure the disease. Cure means
Okay.
after seeing me, a few times, we clear the lesions is not going to come back again. So in this case, in psoriasis, it is not. It will come back again when you stop the treatment most of the time. Yeah,
So, it's basically a lifelong treatment as well.
correct, correct.
So the next question then would be, what are the common signs and symptoms of psoriasis?
Yeah. So as I mentioned just now, the signs are the rash on the scalp, on the areas that we see. Symptoms wise, in terms of itch, not all patients with psoriasis have itch. In fact, most of the time they don't have itch. Only an occasional few patients that they present with itch as well. But patients with psoriasis also can have secondary eczema when they scratch, those
Mm.
lesions, and then they get eczema on top of the psoriasis. So for eczema, we always say that it is if it's not itchy, it's very unlikely to be eczema. But this thing we cannot use it for psoriasis because a lot of times it's not itchy.
So in a way, that's good because it would be terrible to live with a lifelong itch, right? To scratch
Yeah,
like
yeah.
the entire
So
body for the rest of your life.
correct. But we look at severity of the disease, not only how much it is involved, how much lesions is involved. We call it body surface area. Right? That means, of course, if you have 90% of the body surface area having the rash, then it's considered severe, right? But if you have only
Yeah,
2%, it is not severe. But on the other hand, we also look at how it affects your quality of life. And the quality of life
true.
will involve all these things that you mentioned about itch. Although patients with psoriasis, most of the time, like I say, they don't have itch, but it is something that really impacts their quality of life. For example, a lot of people who doesn't know about psoriasis will think that it is infectious. So whenever they take off their shirt in the swimming pool, everyone will be so afraid. Plus, it's so scaly, large scales. Wherever they go, they will be shedding all these scales on the floor, and even it can involve the scalp, right? And so
Yeah.
when the barber shave it, they'll be so afraid of cutting this patient's hair because they would think that it is something infectious, and it also affects their sexual life because psoriasis can affect even the private area, the genitals. Yeah, psoriasis
Yeah.
can happen at the hand and feet.
Any, yeah,
So those days when we need to shake their hands, if your hand is involved, it's considered a severe psoriasis. Yeah,
because it's a surface area that everyone can see,
can
and
see,
and
correct,
it, like you
exposed
said,
area.
shaking hands. Yeah.
Mm.
So
Psoriasis also happen on the scalp, and for the scalp, most of the time the rash will cross the hairline to the
so
face,
you can see
so
it
you can
clear.
see it
Yeah.
obvious. Yeah, obviously you can
Yeah.
see it. So once face is involved, it is considered severe psoriasis.
Okay, that's interesting and actually good to know. So then, what are the risk factors for psoriasis?
My dad has psoriasis. When I was
Okay.
4 year old, he had very bad psoriasis, involved the whole body. He has to be admitted a couple of times to the hospital. So I have about 20% chance of getting psoriasis. Yeah. But so far I still haven't. No symptoms, no signs yet. Yeah, but I always tell my patient, even if I get it now, I'm not afraid because the treatment now is really so good for psoriasis. So genetic is one,
One. Yeah.
definitely. If both husband and wife, I mean both parents have psoriasis, then the chances of the child having psoriasis will be double, will be almost 60%. Yeah.
Wow. Okay.
So my mom doesn't have, so I only have 20% chance of getting risk of psoriasis. Then the other one is environment. But so
Okay.
far, we haven't identified exactly what environment uh, cause psoriasis, or we know what makes it worse, but we still don't know what caused psoriasis. Just like a lot of malignancy, a lot of cancer.
True.
We
Yes.
just don't know what kind of environment. You talk about pollution, you talk about air, you talk about water, you talk about diet. It's so difficult to identify because there are a lot of confounding factors to it. But we know definitely it plays a role.
Yeah. So even like for myself, they say that colorectal cancer is genetic, especially when present in females below the age of 50. But I have no genetic history of colorectal cancer. So it's until today we don't know what is the cause of it.
Yeah,
So what's the risk
yeah,
factor because it's not genetic,
correct.
right?
Correct. But we
Yeah.
know also all this genetic, they can always have genetic mutation. That means they always
True.
start from you, and then once you have the mutation, then only you pass it down. It
To
must start from
I
somewhere.
see.
Yeah. Mm,
Okay.
yeah.
Oh, okay. That's scary.
Yeah. I
So
mean,
Dr. Peter,
um,
um,
definitely not. All this passing down we're talking about is just percentage. So it can be a very low percentage. We are not talking about all those autosomal dominant genetic
yeah.
where it is like 50% chance of getting it. No, we are not talking about all this genetic
Okay.
inheritance. Yeah? Mm,
Not like thalassemia, that type of
mm.
like genetic
Correct, correct. Yeah,
inheritance.
those X-linked autosomal dominant where we know
Yeah, yeah.
exactly, the percentage we can tell you
Yes.
25%, 50%, all this, no? But this is not. Yeah.
Okay. So my next question for you then, I think for those people, especially psoriasis patients watching, is what are the current treatment targets that both doctor and patient should aim for?
Mm. Those days, when I say those days, that means maybe about 10 years ago, more than 10 years ago, we used to say, oh, wow, you get improvement, it is good enough, 50% improvement from your baseline, good, good, but then our benchmark went higher. We said 75%, then we go PASI 90, we call it. There's this scoring system where we call it PASI. It's actually compare after treatment versus before treatment, before the baseline. So if there's 90% improvement, we call PASI 90. then we are happy. But now the aim is PASI 100. That means we
Wow.
want to clear the skin 100%. That means you don't find any rash on the patient. So our
That's
benchmark has gone
amazing.
that. Yeah, but of course, not everyone can achieve PASI 100. If you look at the best treatment nowadays, about 50% of the patients can achieve PASI 100. But only,
Okay.
if you talk about PASI 90, that means 90% improvement, it's about 80%. That means if I start 10 patients on the medication, 8 of them will have 90% clearance.
Wow. That's really good.
Yeah,
That's like
yeah.
80% getting,
Mm.
like, wow. That
And
is a really good aim nowadays.
correct, correct. Yes.
Okay. So then when we talk about treatment targets, now there's PASI 100, like you mentioned.
Mm,
Then what are the
mm,
current and new treatment options that are available to treat psoriasis to make it PASI 100?
yeah. So like 20 years ago, right? When we talk about first, we call it biologics lah. Let's talk about, of course, if you want to start from the basic treatment of psoriasis, patients come with just one patch of psoriasis. Of course, we don't think about giving oral or giving injection medication, right? We always think about creams, topicals, whether moisturizer is a must. I tell my patients, even you and me, Maisie, I think you and me, we
Yeah.
need moisturizer every day after shower. As we age, we will tend to, our skin gets drier and drier, so we need to moisturize our skin. More so for patients with psoriasis. Then, if it's inflammation, then we use things like topical steroids, topical vitamin D. But of course, we need to know where to use the right cream, right? Because if it's on your private area, which is a very thin area, and you apply the stronger steroids, you're going to thin down the skin. So we must know which potency of steroid to use at which site. But then we never use IV, I mean injection of steroids or oral steroids for psoriasis because the risk of using it is, of course, it can clear. Let's say you go to a doctor, he injected you with steroids. Within days, the psoriasis will clear, but after 2 to 3 weeks, there'll be rebound of the psoriasis. It
Yeah.
gets worse. And then you go back again, you inject again. So every month you inject, very soon your bone is, you first of all, you're going to put on weight, your bone is going to get brittle, and if you fall, you're going to have fracture. The risk of diabetes, hypertension, heart disease, and stroke all increase tremendously, and it's irreversible. So those are not the treatment that we want, right? Okay. Then we go to phototherapy. Phototherapy is also useful, but it's just too troublesome, because patient has to come to my clinic 2 to 3 times a week for the phototherapy. For some patients, they can,
Wow.
then it's still an option that we give, especially those who stay nearby. Then finally, we go to systemic treatment. Systemic means either oral treatment or injection. So those days, we use a lot of things like methotrexate. Methotrexate is a weekly medication, but with that medication, we need to check patients' liver function test. We need to check their full blood count because the, they may have hepatitis. The white cell may suddenly drop, and patients are more prone to infection. All this. And then we also have things like cyclosporine. Cyclosporine is also immunosuppressant. We need to monitor blood pressure. We need to monitor kidney function. Then we have acitretin.
Wow.
We need to monitor cholesterol. We need to monitor, again, liver function tests. So those are important medications, but it comes with possibility of side
Right.
effects.
Side
Um,
effects.
we need to monitor closely, and those medications we don't aim that high. We don't aim PASI 90. We don't aim PASI 100. If it's 75% improvement, 50%, we'll say okay, good, and if patient is happy, we'll continue with that. Then finally we come to a generation of this is a biologic era, we call it. Nowadays, Amizi, everything goes targeted. Every treatment is more targeted nowadays. Be it
Yeah.
cancer, be
You're
it
right.
inflammatory disease, because we are trying to find the fault. Where is the root cause of the problem? And then we are trying to correct the root
Target that.
cause of the problem. Target it,
Mm.
exactly. So what is the problem with psoriasis? I always imagine it like a war, you're having a war there, and it's a lot. As a result of the war, you have inflammation, you have this fire burning on your skin. And why it happens is because one of the messenger, war, you have this fortress, this general with this general, they always communicate with each other. But one of this messenger go crazy. For nothing, he go and inform that the other general, there's an enemy coming, and then this general got panic and start producing hundreds of soldiers ready to fight, go out, disperse out, and then he produced more and more and more and more, and the whole thing go crazy. So this is what we call autoimmune. That means your own immune system start attacking your own skin, start attacking your own joints for no reason. So biologics is a protein. It's made from protein. The function is an antibody. It's also a soldier. We are sending a good soldier into your body to capture the problematic soldier. Where is the naughty messenger? Go and catch him. And you catch him. Once you catch the messenger, there's no false news. All the generals will be stand down, everyone peacefully, happily. So there's no inflammation. That's how it goes.
Mm.
If you talk about steroid, they're also anti-inflammatory, but the problem is they capture everyone. They capture the
Everything.
general, everything. So your immune system goes down. When the real enemy comes, when COVID comes, oh no, you can't
Yeah.
fight COVID. That's why immunosuppressant is not the ideal way to treat psoriasis. This is all these
So
biologics, we call it immunomodulator. Yeah.
immunomodulators. So the
Mm,
most important word now is targeted treatment for psoriasis,
correct.
using biologics. So I
Correct.
think that is the key word for those psoriasis patients out there who are tuning in. Again, if you're new, you probably don't know, but you can ask questions for Dr. Peter. He is here live now. I would suggest and advise you to do so because after this show is over, Dr. Peter won't be on anymore and we cannot ask questions. So please use this opportunity to ask the questions now. We'll pick it up in a short while. I have just two more questions and two myths I would like to ask Dr. Peter before we open the floor. So, Dr. Peter, the next question is I think you did answer it sort of already. So, how do you decide the right treatment option and treatment goal for your psoriasis patients?
So, first of all, I look at the severity of the disease, right? So whether
Mm,
the rash, if it's more than 10%, we call it severe. And it involves
okay,
important areas, like we say face, hand and feet, the private area, genitals, then we consider severe. If it involves the joint, because if there's joint inflammation, you go and apply cream, it's not going to absorb into the joint. You need
into the
something
joints, yeah.
you need something from inside, either oral or injection, right? You need something from inside. And of course, those who fail topicals, there are some patients, wow, very resistant rash, or they are so not compliant to creams, even though it's just 8%, but they still don't want to apply the cream. Of course, it's not going to go away. Then you discuss with them whether you want to be put on systemic agents or not. So based on that, and also of course, we talk about finances. Also, it must be affordable for the patients. So we don't say, oh, you can't afford this medicine because it's expensive. Then that's it. Of course, there are second options, right? Then those oral treatment that I mentioned just now, they are very affordable. Yeah. But of course, we need to monitor for side effects, like I mentioned. Whereas
Mm,
for biologics, nowadays it is very safe for biologics. We have not come across any side effects, and yet they have a long-term study to prove that. Even for me, I have at least about 6 years experience of using the newer biologics. The older biologics, I have experienced more than 10 years of using that. But the newer ones, yeah, why newer and older? The older generation, they target higher, like I said. They target not the general lah. They target the one of the important ranking soldiers. So with that blockage, there was still risk of tuberculosis. that means a lung infection. So, uh, so it's still something that we need to monitor closely if patients are on older biologics. There are still older biologics being used, yeah, but we tend to use the newer biologics nowadays.
So the three main things you usually look out for before deciding the treatment is first severity, and then you look at compliancy, and also you look at price, like the
Yeah,
affordability for the patient.
yeah.
Right.
Of course,
Okay.
the suit whether it's very individualized. Like at the end of the day,
Yeah.
I can't really, but the general it generally is all these things. But of course, we have to look at other things as well. Like for example, if patients have let's say hepatitis already, so other options are dun dun
Comorbidities.
dun 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 all
Yeah.
out
Yeah.
already.
Yeah.
Half of them out already, so you're left with that. Or patients wants to get pregnant and then dun 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 dun, dun, again all this out, left with this. So
Yeah.
mm, yeah,
Okay.
so every treatment should be individualized.
Okay, that's good to know, and good for the patients to know that as well.
Yeah,
My last question before we open the floor to questions is what is your opinion in a doctor-patient shared decision making related to management of psoriasis? I think you just covered it actually in terms of
so
management
important.
to
Yeah,
this. Yeah,
it is so important. I always, spend my first consultation. Patients know that I spend really long time talking to them during my first consultation. I will also tell them about what can make your psoriasis worse, what can trigger your psoriasis. And once you are equipped with all this knowledge, you can make the decision yourself. Don't be pressured. Don't not
don't
just
listen
because
to.
yeah, not don't just biologics is the most expensive, then you go for biologics or whatever. You have to weigh between because this is a chronic disease, so you have to think long term. I always tell them, don't think about the short term. I don't want you to carry you to heaven, clear the lesion, and then suddenly I have to drop you down from heaven, all these things. So we want a long term sustained control of the disease.
Okay, I agree. So I think all patients should take note of that and think of it for the long term basis. Okay, so that is all for my questions. I only have two myths I would like you to debunk, Dr. Peter.
Sure.
The first is psoriasis contagious? Yes, no, and why?
Why? No, it is obviously
Okay,
not contagious. Why? Because it's not an infection. Only
okay,
infection is contagious, either bacterial, viral, parasite. So, psoriasis is neither. Psoriasis is an inflammatory disease. It's just inflammation due to autoimmune
mm,
disease, like I said. Yeah? So definitely you won't get, just like eczema. You won't spread. I mean, you won't. Yeah, you won't infect other people, right? So don't worry about
yeah.
psoriasis, eczema. Definitely, it's not infectious. You can share utensils with them. You can sleep with them. You can, wash your clothes together with them. So don't worry, really. This is very important.
Yes, this is a
Mm,
public education program, and this is for
correct,
everyone to know that. So
correct,
the
correct.
next myth I would like you to debunk is there is a cure for psoriasis.
Mm, no, unfortunately, there's no
Okay.
cure for psoriasis. Although, just now I said most of the time. The reason why I say most of the time is I do have some. I call them miracle. Yeah, because like I have a patient, very bad psoriasis. He came to me before his honeymoon. Yeah, and then we started biologics, clear the lesions, and after just and after he showed me photos of his honeymoon, very very with clear skin and everything. But since then, when we call him up and ask, he said it's still clear, despite not continuing the biologics. Yeah, so
Wow.
there will be cases like this, but don't. It is unusual. I call this miracle. So so when
So
you
there
want
are
to,
miracles.
there are miracles. Yeah. it is not due to traditional medicine, these miracles, you know. But don't know if
There's no cure for psoriasis.
there's no cure. Yeah, you
Yeah,
just think of it as no cure. But of course, sometimes when the skin gets better, it is easier to control. At that time,
to
maybe
manage it.
to manage it, you only need to extinguish the fire. I always say small fire. You take a glass of water, you pour on it, it's gone. But now the fire is too big that you need something. You need to call a fireman in.
Mm. Yeah, I agree. So thank you so much for debunking those two myths, Dr. Peter. That was really enlightening to discuss about psoriasis and the myths behind it. So I see people have already posted their questions. So Dr. Peter, and to all the viewers, I'm opening the session to questions now. You can start putting in your questions. I'll try to pick up as many as I can before we thank Dr. Peter for joining today's show. So, good afternoon to all of you. I see all of you said hi. I didn't manage to see it till now. So, I'll take the first question from Eric. His friend actually had colon cancer, and it was removed in 2019. A colostomy bag was used, and now he's suffering from all kinds of skin problems. It's very itchy, red patches all over the body, including the scalp. He asked whether you think that colon cancer with the surgery affected his skin. Thank you.
Yeah. So obviously I don't think this is psoriasis. Yeah. If it started off from the colostomy bag, right? Although, if you want to think very far off with psoriasis can happen at the site of trauma. Meaning, if you cut your skin, if you have underlying psoriasis and then you cut your skin, psoriasis can happen at the site of trauma. So sometimes we do see patients after the surgery, the psoriasis happen at the site of scar. But now, since it's a colostomy bag, most of the time is due to the irritation from the feces, from
Mm,
the plaster. Colostomy is very sticky, and because of the glue over there, the adhesive over there, and also the sweat, and plus the say feces and water itself is an irritant. Imagine if you soak your hand in the water for a long period consistently, you're going to get eczema on your hand. That's why COVID-19 nowadays we get more and more hand eczema. It's because of
mm,
overwashing. So same thing over there. Then from there,
okay.
if you don't rectify the problem, I always say, if your house is on fire, you don't extinguish the fire, what happened? It's going to spread to your neighbor, right? So the
Yeah,
surrounding skin
I
will be
see.
all inflamed as well. And if the neighbor, you still don't extinguish the fire, what will happen is going to spread to the whole village. So you're going to have
I
itchy
see.
scalp, itchy there, itchy here, and everywhere. And then patients start using some funny things, minyak cakapat lah, this don't know what liniments lah, try their best and then
Yeah.
rojak things lah on the thing. And then the fire gets even bigger and bigger. So that is one possibility. Because without seeing the lesions, I can only guess. So
Mm,
another guess is perhaps Maisie will tell you more about this. And after this, right, you talk about breathing, exercise to reduce stress because
stress,
stress is so
huge
important.
factor.
Yeah, I divide into psychological stress, knowing that you have cancer and everything, and the physical stress that you go through because of the surgery, because of the chemo therapy. It is no joke. So all this stress will definitely worsen the eczema.
So you think it's eczema? I mean, like
I
you. I mean,
I guess
yeah,
it's
yeah,
really a
not yeah.
guessing
You
game.
guess. Yeah, it's
Yeah, I guess.
assumption. Assumption. Okay.
Yeah.
Thanks, Dr. Peter, for answering that. And Nicholas had a question. He says, "Hi, Dr. Peter. On average, how long for the patient to achieve PASI 90 or PASI 100?"
Okay. So it depends. Let's talk about biologics, right? But since you mentioned PASI 90, PASI 100, we go for biologics. And of course, there are many different types of biologics, different brands available. So certain brands, I can say that within a month or two, you can already achieve PASI 90, for
Mm.
certain
Wow.
brands. Yeah.
Okay.
Yeah. And some, of course, some biologics is to be injected every 3 monthly. So basically, when you let's say you inject today, 1 month later you inject, and then every 12 weeks you inject, you know, the medication.
Mm.
So of course those, then you expect by the time the about 12 weeks to 16 weeks, then you can achieve that PASI 90 and 100. So it is not something that is super slow, or it's pretty fast actually. And all my patients are happy with the speed of onset.
Yeah, 12 weeks is actually really fast. It's about three
Mm,
months to four
yeah,
months.
because it's,
Yeah.
you're talking about from very thick rash,
Yeah.
to smooth skin. Yeah.
Okay. So the next question is Dupinder says that her daughter goes into war when she's stressed with exams. But when her exams
Sorry, goes
end, then
into
she's
what?
fine.
Sorry, goes into
You know,
what?
you mentioned war,
Oh,
like her
oh.
skin flares up.
Okay, okay,
Yeah.
yeah, yeah, yeah.
And she's fine after her exams, and the psoriasis is then manageable. So yeah, she agrees with you.
Yeah,
Um, I
so as long as she doesn't have a war with you, then it's fine. Yeah,
yeah,
yeah. So
so true.
and for those patients, I always say, don't do anything. You don't have to escalate your treatment. You know, and of course don't de-escalate your treatment, don't have to change your treatment, because once the stress is over, like let's say exam is just a short period of time, maybe at that time you just need to apply more moisturizers, you know, whenever you see a rash you quickly apply some mild topical steroids, or depending on the areas, right? And once the exam over, you're back to what before the exam, which is well controlled. So do not escalate the treatment because of all these triggers.
Mm,
And I
yeah.
ever mentioned
Okay.
just now about the triggers, right? My pneumonia is TIMES. T is for trauma. Anything you're traumatized, psoriasis can happen. I is for infection. If you get a fever, sore throat, dengue, then the psoriasis will flare as well. M is for medication. Certain medication like hypertensive medication, they can trigger it. E is for endocrine. That means hormone. So certain hormonal change. Some patients with thyroid disease, they can also flare. S is for stress. We have mentioned it. Smoke, and spirit, which is alcohol. Alcohol can trigger psoriasis also.
Okay. Well, good to know. The next, I'll take two or three more questions because, yeah, our time is running out. So, Madam Yo asked, how can she differentiate between eczema versus psoriasis?
Hmm. So, I mean, the the sh- the the short answer is you have to go and see your skin specialist. But if I can describe it a bit, for psoriasis, like I said, the color is very peculiar. Once we see it, we know it. It's salmon pinkish in color with the silvery scales. And then we look at, whereas for eczema is just red or pigmented, and then with the fine scales on it. Psoriasis, the margins are very well demarcated. That means we can draw exactly where the margins are. But whereas for eczema, there are three stages, a bit more complicated. Sometimes watery, sometimes scaly.
Mm,
But the most of the time, the margins are not so well defined. Then the location gives us a very good clue, you know, because like I said, psoriasis mainly happen on the scalp, crossing the hairline, the extensors. We have nail changes, whereas eczema is confined to the scalp most of the time and with no nail changes. So family history, all these things come together to make us make the right diagnosis, because it is a
mm,
clinical diagnosis. There's no blood test for it. We don't biopsy psoriasis lesions. Very, very rarely we need to biopsy.
okay. Thanks, Dr. Peter. My second last question is from Eric again. He asks, screenings are available for cancer, but are there screenings available for skin health?
Yeah, I obviously, you know, God created the skin outside. It is the biggest organ. So when He created outside, what is the best tool to look at skin? It is your eyes. You know,
I see.
the rest of the
So
cancer is inside. You know, that's why you need to
inside,
try to take
yeah,
blood and then try to detect it. No, we don't need to. Yeah, it's easy job for us. We just look at the skin. Even
yes.
for skin cancer, there's no tumor marker for skin cancer. We just look at the lesions. Of course, we have a help with what we call dermatoscope. It magnifies 10 times so that we can look at we call it morphology. We can look at the pictures of the lesions to tell us whether this is cancerous or not. If we think it is suspicious, then we're going to biopsy it. We're going to take it, just like any cancer, we biopsy and send it to the lab.
Mm. Okay, I didn't know that. That's good to know. And my last question from the audience is, her scalp has psoriasis, and she says it's a never-ending story despite using Zymol. Anything else you can suggest for her to try?
Yeah, indeed, scalp psoriasis, if it's very extensive, sometimes it's very difficult to control. So what she mentioned about Zemiol is actually steroid plus a vitamin D. It's a gel form. Well, you can try to use twice a day. Certain shampoos combined with even a steroidal shampoo. Just don't worry about steroidal shampoo on the scalp because all these are not leave-on product. You wash it off, right? So I would say put on the steroidal shampoo, wait for about 10 minutes, rinse it towards your back. Yeah, you don't want all the steroid to go into your eyes. That's the only thing. So rinse towards your back. So with that, if it's not suitable for you, try other things like betamethasone combined with salicylic lotion. And if it still fails, then some of my patients require systemic treatment. Systemic, like I say, either oral or injection.
Mm.
It is
Thank
different
you.
from one person to another. Like
Individualized.
some patients is really so easy to control, but some patients are very difficult to control. Very difficult to control. I will dig into the compliance as well. Yeah, because some patients
Mm.
their definition of not control is when I use it 1 week is clear and then it comes back again. For them, this is not control, but actually it is not. It managed to clear it. It's just that when you stop it, it comes back again. And I always say
Mm.
you don't use it just enough to remove the scales, but when there's still fire underneath your skin, even if it's clear, you want to use it for maybe another week until it's smooth.
Yeah. Thanks a lot, Dr. Peter, for answering the questions from the audience. And thank you all for your questions, for staying tuned so far. Dr. Peter, before you leave, I have one more question for you. Can you advise when should a psoriasis patient seek a dermatologist?
I think if you're not sure about the diagnosis, go and seek opinion from a dermatologist because a lot of times um, when patients come to me, they don't even know that they have psoriasis. Um, and of course, when it comes to difficult lesions where creams won't help, right? Yeah, when you go to your normal family doctors where they have prescribed you with certain creams like topical steroids, and it just not well controlled, then please seek help from us.
All right. Thank you so much, Dr. Peter, for sharing, for answering all the questions, for allaying our doubts and debunking those myths. I've really learned a lot. I'm sure the audience have really learned a lot. Thank you so much. We're honored to have you on the show today on Talking Live with Macy, and thank you for making time. We really, really appreciate it. Thank you so much, Dr. Peter.
Thank you.
Take care.
Bye
Have a good
everyone.
Sunday.
You too.
Bye. And
Bye.
now we have our next guest. Thank you, Dr. Peter, once
Thank
again.
you.
All right, and now we're gonna. I mentioned we're having a very special segment for this episode and the next two three-part series on psoriasis, an educational program on Talking Live with Macy. So we had such a good session with Dr. Peter, and today we're really thrilled to have another special guest. She will be facilitating a breathing technique session, like what Dr. Peter said. Stress actually increases the inflammation. So in order to reduce the inflammation, we have to reduce stress, and breathing techniques actually reduces the inflammation by reducing the stress. And one of the major triggers for psoriasis is actually stress, which is what it does to fuel inflammation. So it's likely to increase the severity of psoriasis symptoms. So, like doing things like breathing techniques as little as 10 to 15 minutes a day actually improves psoriasis outcomes in the long run. So, to many of us, our special guest, which she's already on, needs no introduction. She's the founder of award winning Ohana Jo, voted as the number one yoga and sound healing studio by Tourism Malaysia in 2020. She's a regional TV host, TEDx speaker, certified sound healer, and accredited yoga teacher. So, let's welcome Jojo Struys. I'm going to pass the session on to her and I'm going to follow her breathing technique. Thank you.
Thank you so much. Thank you for having me. Well, stress is a huge, huge factor that is affecting all of us. And I would say that it's also because we're living right now amid so much change. So there's a lot of uncertainty. And you'll know if you are feeling anxious because your chest might feel a sort of tightness. And they're generally about, three breathing zones. You've got the lower, the mid, and the upper. The moment we are in a panic attack or we're nervous, we feel that feeling of we're just not breathing properly because we are shallow breathing. So, what deep breathing can do, and there's so many techniques. I mean, I've been doing breath work for more than 25 years, and it's very humbling because I'm still discovering new techniques today. There's so much out there, but the amazing thing about breath work is that it can really calm your nervous system. It raises your immunity, even your memory and your concentration. But most importantly, it helps us to channel out that stress because it puts you in the present moment of now. And that's the whole idea. I mean, meditation is about clearing mental clutter. So when you feel that you're shallow breathing or it's tight, that is a perfect time instead of reacting to the stress or the anxiety or a thought that might suddenly hit you to just slow down the breath. Because when you slow down your breath, you slow down your thoughts, your heart rate, everything is connected. Your pulse starts to reduce, inclusive of your blood pressure. So, what we're going to do now, all right, is we're going to just try and place one hand on our chest and one hand on our stomach. Now, take an inhale for me, take a deep breath in. And the hand that moves first is how you are breathing every day. That means you are either leading your breath from up here or from the belly. Now, more often than not, when I do corporate training, a lot of people do this and their shoulders lift. That means you're actually breathing from your chest, which is the zone of nervousness, panic, and anxiety. So, what we want to do is we want to keep the shoulders still and we want to take the breath from our stomach so that we can do deep belly breathing, which is amazing for the diaphragm and your heart, rather than from your chest. How we're going to do this is as you inhale, you're going to allow your belly to move away from the body. So it expands like a balloon. Okay? And the shoulders and the chest really are not going to be moving at all or very little. So let's try that. As you inhale, allow the belly to expand. Breathing in, feel it fill up with oxygen like a balloon. And as you exhale, breathe out from your nose and observe the passage of the breath as you breathe out. Now we're going to try this a few more times just so you get the hang of as you inhale, the belly moves away from the body, and as you exhale, the belly relaxes and softens and it moves inward as you breathe out. Okay, so let us try. Inhale, belly moves away from the body and expands. And as you exhale, it softens as it sinks. Breathing in, feel that movement away from the body like a balloon. And as you exhale, out from your nose, feel it soften. Can you feel that, Maisie? Yeah? Okay, so now what we're going to do is we're going to do a 4 square breathing method, which is amazing for stress as well as anxiety. We're going to breathe in for 4 counts. We're going to hold the breath for 4 counts. From your belly, you're going to exhale for 4 counts, and you're going to hold the breath out at the bottom of the exhalation, also for 4 counts. Now, what this is going to do is it's going to completely slow down the rate of the breath. You'll start to notice maybe a kind of a sinking feeling of I'm sinking into the moment. Remember that a lot of your stress is coming from the fact that you're thinking about your past, which we can't change because whatever happened yesterday can't be undone. words that you wish you hadn't said. If they've already been said, we need to let go. So if you are continuously thinking about your past, they say that that's more lending toward depression and worry. If you keep thinking about the future, well, they call that anxiety. So we want to be in the now, because really it's this moment of now that we've it's the only moment you've got control over. So when you're doing breathing techniques, it's forcing you to focus on your breath, focus on your body, focus on this moment, so that we're not thinking of the past and we're not thinking of the future. Okay? So let us place one hand on the belly. You don't have to have this hand up here on your chest because we want to breathe from the stomach. I'm going to even move further back. All right, so as you breathe in, I'm going to count this for you. Inhale, 1, 2, 3, 4. Hold the breath in. 2, 3, 4. Allow the belly to soften as you exhale. 3, 4. Now hold the breath out. 1, 2, 3, 4. Close your eyes. Really get connected with your breath. Feel the passage of the breath as it moves in and out of your nose. Inhale, belly expands. 1, 2, 3, 4. Hold the breath right here, holding it in. 2, 3, 4. Slowly exhale. Allow the belly to soften as it draws inward toward the spine. 3, 4. Hold the breath out. 1, 2, 3, 4. Inhale, belly expands. 1, 2, 3, 4. Hold the breath in at the top of the inhale. 2, 3, 4. Exhale slowly out from your nose, releasing the breath. And now holding the breath out. 1, 2, 3, 4. Inhale, belly expands. Holding the breath in. 2, 3, 4. Belly softens as it relaxes. Take your time. Now holding the breath out. 2, 3, 4. And now just closing your eyes, breathe normally. Just observe the passage of the breath, bringing all of your attention to your upper lip, that space in front of your nose. Allow the mind to go quiet. You can observe your thoughts without being attached to them. Allow them to pass, like an observer looking at clouds, allowing them to floating away like clouds in the sky, without reacting, without judging your thoughts, without judging yourself. We're just watching the passage of the breath. We're going even into the micro detail in mindfulness of how does the air feel? What is the temperature of the breath as it moves in and out of your nose? Maybe you might notice that the air is a little cooler on the inhalation and it's a little warmer on the exhalation. And without needing to hold the breath, but breathing from the belly, deep belly breathing, just observe any differences in body sensations. Perhaps you may experience a kind of a sinking, feeling lighter, as if you are releasing what no longer serves you, and at the same time, really settling, feeling your sitting bones, making that connection with whatever you are sitting on right now, being very aware of your body, aware of the sounds around you, whether it's the aircon or the fan or the street outside, allowing these distractions to melt away. We are focused on the upper lip and we are listening to the breath. We are feeling the breath as it moves in and out of your nose. just watching the breath, observing your thoughts without attaching and holding onto them, just allowing them to pass like a slideshow, watching them float away. And right now, in this quiet space within yourself, set an intention for whatever you need to release in your life. This could be stress, it could be a relationship, it could be a feeling of being overwhelmed, it could even be a fear of uncertainty, a fear of not knowing what's coming up. And that's okay. So, whatever your intention is, we're going to now take a really deep inhale together. Take a deep breath in. Let's do this together and hold the breath. Imagine breathing in unconditional love, a sense of internal peace, breathing it in like a light and allowing it to circulate all around you from head to toe. And now, as you exhale, letting go that fear, letting go that stress. One more deep inhale, breathing in and hold the breath here for 1, 2, 3. Exhale, release. Breathing out everything you do not need. And now, hopefully, feeling more grounded, more self aware, more mindfully present. Gently open your eyes. And we're going to raise our hands up. Take an inhale. Hands up. Lengthen the spine. Exhale into cactus. Out through the mouth. And you should hear yourself like a sigh of relief. Inhale. Hands rise. Exhale into cactus. Letting go all that tension. 3 more. Inhale. Exhale. 2 more. Inhale, breathing in positive energy, fresh beginnings. Exhale, letting go the past. Now just roll your shoulders back 3 times. That's it. Place your right hand on the outside of your left knee and gently exhale as you twist. You can do this sitting in a chair as well. Inhale, come back. Left hand on the outside of your right knee. Exhale as you twist. Inhale, coming back. Just roll your shoulders back for me 3 times. Roll your shoulders forward 3 times. And one more time. Inhale, hands rise. All the way up. Lengthen the spine and feel the breath traveling up your spinal column, up your back and your arms, your wrists. Exhale, up and up. Two more times. Hands rise. Exhale at the side. Something else. One more. Inhale. Hands rise. So we basically we did the 4 square breathing method where you take the breath from your stomach, you inhale for 4 counts, hold the breath in for 4 counts, you exhale for 4, and you hold the breath out for 4. And it's really just to be more aware of breathing from your belly rather than the chest, which is the place where we experience shallow breathing, panic attacks, and tightness.
Thanks a lot, Jojo, for the breathing techniques exercises that we learned today. It was really, really amazing. I meditate myself every morning to start the day, and I find it very beneficial for myself. Thank you so much for the first session. Jojo will be joining us for the next 2 sessions. This is the first episode of a 3-part series on psoriasis. We will welcome you back in the next 2 episodes as well, where you will be teaching more breathing techniques for everyone on the show. So, And that ends our first episode of a three-part series on psoriasis awareness and education. Thank you for staying with us till the end. Thank you so much, Jojo. We hope you've learned a lot from both our experts today, both Dr. Peter and Jojo. And once again, I would like to give a word of thanks and recognition to the Dermatological Society of Malaysia and Psoriasis Association of Malaysia for endorsing today's program. We couldn't have done it without both of these societies, or rather associations' support. Psoriasis is not contagious, and there is no cure for psoriasis. These were two myths that we debunked today. We learned so much about patients living with psoriasis and how to improve their quality of lives, the right treatment targets, and management plans. So, if you think you have psoriasis, please consult your dermatologist early, and please stay tuned with us for the next two episodes on our three-part series. The next two episodes will be on the 5th December and 12th December to learn more about health conditions associated with psoriasis. And we'll be debunking more myths. We're going to have more breathing techniques as well from Jojo. Thank you, everyone. Stay safe and stay healthy. Have a good Sunday ahead. Thank you. Bye, everyone. Thanks, Jojo.